So let's talk about TMS. TMS has only really been in clinical use since 2008. The technology itself was invented by a British guy named Tony Barker in the late 1970s. And I'm going to start out with a little bit of a technical explanation of what it is, but don't worry, that won't be on the test. All right, so what is TMS? It's a non-invasive procedure using an electromagnetic coil. You know, this gets into physics and Faraday's law, but basically there's a relationship between electric fields and magnetic fields. And so we can use a magnetic field to induce electrical activity in the brain. So with the TMS device, the electricity will flow through the coil itself, but not into the patient. So we're not applying any electricity to the patient. We're just applying the magnetic field, but because of that relationship between electricity and magnetism, there will be induced electrical activity in the brain. And the neurons in the brain are essentially linked and talk to each other through both electrical signals and chemical signals. And so we can actually manipulate the neurons and cause those electrical signals to go from one to another and modulate the activity of a brain circuit. And in this case, the brain circuit that's regulating the person's mood. Most of the treatment indications for TMS require a series of repeated treatments. So it would be daily treatment sessions, Monday through Friday, for a total of 36, and up to 50, or maybe even more than 50 in some research protocols. The initial study on TMS that it got FDA approved for depression, the lead investigator was going to do 7 days a week. He thought, a treatment every day, we'll just kind of grind through them. And when he was telling his wife about it, she said, we're going to get a divorce if you do that. And he was like, maybe 5 days a week is okay, so we'll do that. And that was good enough, and it worked. So there's always a question of why 5? Could we do 4 days? Could we do 3 days? We don't know, but maybe. So there's different kinds of TMS coils, although almost all of them, and I'm going to show you what they look like, but they're almost all in a figure 8 shape. There's one that's called an H coil, and let's take a look. So the one down here is the BrainsWay device, and that one is different than the others. So it's got, you can see the blue one and the yellow one here are 2 different coils for that device, and they look like a helmet. So for that one, essentially the patient, they put the helmet on the patient's head and they strap it on with a chin strap. The other coils, well, you can see the devices have like what looks like a dentist's chair, and then a cart next to the device with an arm. Look at the MagVenture one here, there's an arm there and it's holding the coil right there. So you can, the patient will sit back in the chair and then you can position the coil on the patient's head like this, into the position you want. So what do you do with TMS? So all of the 7 devices on that previous slide are cleared for treatment of treatment-resistant major depression disorder in adult patients. So every one of those devices can treat that. 2 of the devices are FDA approved for obsessive compulsive disorder in adults as well. And that includes that funny looking helmet device. It has the OCD approval. The next item though, migraines with aura, that wasn't shown. The device for that wasn't shown on the previous page, so I've never seen that device or known anybody that's used it, but there is a device out there that can be prescribed by a neurologist for home use for migraines. And so the patient actually with that one would put the device at the back of their head and deliver one single magnetic pulse to the occipital cortex to try to stop the migraine. So it's interesting. I don't know why you don't see it or hear about it or use it much, but one of the devices, that same helmet device, is approved for smoking cessation, and that's kind of an interesting one. It's the data on that wasn't super impressive. You know, it got the approval, but the success rate was 27% with the active treatment and 17% with the placebo treatment. So not super impressive, but to have an approval in that sort of addiction space is cool, and you know, interesting that they could move in that direction and maybe find some other things it can do. Anxious depression was interesting when that approval came out, because you know, all the devices are already approved for major depression, and if you treat patients with major depression, you know, a lot of them have anxiety, and some don't, you know, but a lot of them do. So, you know, what is anxious depression? I mean, it would be somebody that has major depression with comorbid anxiety as well, and 2 of the devices have a special approval for that, even though all the devices can treat depression. So here at the bottom is other potential indications, you know, stuff that there's been research on. It's exciting. We don't know how that's going to pan out yet, but there's pretty promising data for using TMS to treat neuropathic pain, post-stroke pain as well, PTSD, and fibromyalgia. So 3 out of the 4 are sort of pain, you know, chronic pain conditions, which, you know, if you think about opiates and the opioid epidemic, it would be super, super cool to have like a non-invasive, non-medication option. So I hope we see that happen. And PTSD, I mean, PTSD is a condition for which psych meds are really kind of meh, you know, just kind of mediocre. There's therapy modalities that you can do for PTSD, but we would be nice to have something else we could treat that with. All right, so how do you get TMS paid for? By insurance. This is from the Medicare criteria. So our version of Medicare, the Palmetto GBA Medicare in the Southeast, will cover TMS for major depressive disorder, severe, and obsessive compulsive disorder. And these criteria are going to vary a little bit from insurance to insurance, but right now, Medicare and all the insurances really are requiring the depressive episode to be severe. And you can measure that with any of the rating scales. So I usually use the PHQ-9, but you could use the Hamilton or the Madras, or you know, the Quids or whatever you want. But with the PHQ-9, any score from 15 to 19 is considered moderately severe, and a score of 20 and higher is considered severe. You know, so which one of those ranges will be good enough for the insurance company depends. So Medicare, I say it's okay with a 15 or higher. I think Humana and Cigna will accept that. Blue Cross is very stringent, and it has to be a 20 or higher on this. But that is a subjective, you know, self-assessment type form, and the score varies over time. If the patient has a really lousy week and takes a PHQ-9, their score goes up generally. So it's not that hard to score high on those. In addition to being severe, the patient has to have either tried 2 antidepressants and those failed to work, or they couldn't tolerate them, or if they didn't try 2 meds, but they had TMS before, maybe for whatever reason they paid out of pocket for TMS without ever trying meds, and the TMS worked, then that's a previous successful treatment, but then they got depressed again. The next time around, the insurance could cover it on that basis. If they're currently getting ECT, do y'all know what that is? Electroconvulsive therapy or shock therapy in the hospital, and they want to switch to something less invasive, that's a good enough reason for insurance to cover it. And with Medicare and Blue Cross and most of them, the patient has to have had an adequate trial of CBT or interpersonal therapy. Optum, United Healthcare removed that requirement. So now United only requires 2 medicines and no therapy. Obsessive compulsive disorder is less widely covered at this point. The approval for that came later than the approval for depression, so it hasn't been approved as long. But Medicare does cover it. Blue Medicare covers it, and I think in our area that's it. Regular Blue Cross and the other commercial insurance companies don't have criteria for OCD treatment. But if the person has both, if they have OCD and they have major depression, I can get it approved for major depression, and then you can do the treatment that works for both at the same time. And the criteria is similar. This is the Medicare criteria, and they have to have tried 2 antidepressants or have had a positive response to TMS in the past, or, and I thought this was kind of interesting, if they're on what's considered a risky treatment for OCD, and on that list includes antipsychotics, benzos, opiates, and memantine, which I didn't even know they were using for OCD, but apparently it's a dementia drug that you could use for OCD. And if they're on that, it's risky, and TMS is a good alternative. They would also have had an adequate trial of CBT or exposure with response prevention type therapy. And why would you pick TMS versus other treatments that we have available? So that's pretty much what this slide is about. Because TMS is a focal treatment, so we're actually directing the treatment right at the brain, you're not getting the systemic side effects in the body. So medications oftentimes can cause GI issues, sexual side effects, weight gain, that kind of thing. So TMS doesn't do any of that. So that's kind of a nice benefit there. The next point about cognitive side effects, there aren't any with TMS. I think that's really in comparison to ECT, right? So you get memory loss or confusion sometimes with ECT treatments, and you don't get that with TMS at all, so that's a real win for TMS. It's non-invasive, so there's no sedation, anesthesia, or recovery time, so that is also a benefit for TMS over ECT, and it's effective in treatment-resistant depression, right? So the data on the graph here on the left is from the STAR-D trial, and it shows that, in 27 or 28% of patients on their very first antidepressant trial will achieve remission of their symptoms. And it goes down, that percentage goes down with each successive medication trial. So if the first one didn't work and they take a second antidepressant, the odds of that putting them into remission go down to 21%. On the third try, it's 16%. And on the fourth try, it's 7%. So it's getting pretty low, the odds. The arrows say, TMS is indicated here. If they've failed 1, 2, or 3. Of course, the insurance company doesn't agree that if they failed 1, TMS is indicated there. But if you look at the odds, take a look at some of the data for TMS efficacy, right? So this is Linda Carpenter's data from Brown from 2012. In her patients, better than half were responding, and about a third were going into remission. And keep in mind that the patients we're talking about are the ones that are treatment resistant. So if you've got a patient that's tried 4 medicines, which would have been the insurance criteria, the odds of them responding now or going into remission from medicine number 5 are going to be less than 7%. And the odds of them going to remission here were like a third of the patients. So that's pretty cool. And these, efficacy rates vary from data set to data set, but they're all pretty high in comparison to medication. All right, let's talk about tolerability and contraindications. It's really not bad. I mean, you can get some discomfort at the application site, which means, the scalp, right here, of a zing, from that magnetic field. So as the field goes through over here, there's a peripheral nerve that controls the muscle that makes you raise your eyebrow, and so the patient's eyebrow may go like this, during the treatment, and so they'll feel that. And there's a lot of descriptions from patients of how that felt getting the actual stimulation. A lot of them say it's like a woodpecker, even though none of them have ever been, pecked by a woodpecker. That's a popular one. It could feel like a TENS unit, for people that have tried a TENS unit, it might feel like a little bit like that. They sit in the chair and we do the magnetic stimulation for 10 minutes, maybe 20 minutes, depending on the protocol. And afterwards, they can have some mild discomfort in the scalp, but nothing a Tylenol won't take care of. So the patient, and this is rare, but a patient that has cochlear implants for hearing would not be able to get TMS. If they have metal in the head that prevents them from getting an MRI, then they could not get TMS. But the magnetic field for TMS ends right about here. I mean, it goes like 30 centimeters or 12 inches about. So anything in the body is not going to be affected by the magnetic field, only in the head. And dental stuff is not a problem. So they're not using ferromagnetic metal in your fillings or dental implants. So you're good with that. So I have treated somebody that had a vagus nerve stimulator. It was an old one that was, dead. I guess the battery was dead or whatever, but the leads were still up in his neck. That was fine. So the field did not reach those leads. In 2017, the machines got better with cooling, so you could do that many pulses in half the time without it overheating. So that went down to 19 minutes. In 2018, they came out with a new protocol, like a new pattern of stimulation. So the previous patterns had been 10 hertz, which means 10 pulses per second. And this one, the theta pattern is totally different, and it's based on, or kind of patterned after, a natural brain rhythm, right? So there's a theta oscillation rhythm that can be seen in the brain, in the hippocampus and in other parts of the cortex, and it happens during REM sleep, and it happens during certain activities or behaviors. And they thought, hey, let's try this natural brain rhythm and we'll kind of copy it and use that and see if it works. And it does work. It doesn't work really any better than the old way. It works just about the same as the old way did. But it was way, way faster, and you didn't need as many pulses, so you could do it in 3 minutes. So that happened in 2018. You need 2 MRIs. You need a structural MRI and a functional MRI, and then you can feed that into a cloud-based system that will identify a different location. So the normal treatment location that we can just measure, with a little kind of a fabric ruler around the patient's head is kind of up here, and the locations that they're finding by MRI data are like further down on the side. And to get to that spot precisely, you gotta have the right setup, and you have to have the MRIs. It's clinically safe and well tolerated for almost all patients, and is currently approved for major depression and OCD. That's treatment resistant. That's what we're using it for 99% of the time. And then there's a couple other interesting approvals for smoking cessation and migraine, which you don't see used as much, but are cool.